Hello, everyone, and welcome to our live session today. I will be going over a quick starter presentation to welcome you all and introduce you to our program and opportunities if you have, of course, not previously attended one of our shadowing sessions. I want to highlight that Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, no matter their demographic status, abilities, or location. My name is Jesus. I am the Chief of Program Planning here at PHS, and I want to thank you all for attending today. So we will get started. Okay, let me. Just a little PSA right over here. We do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your screen. And if you need assistance enabling the transcript, please direct message one of our team members, which are the people with the blue background behind them. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have recommendations for how we can improve, you can definitely email us at info@prehealthshadowing.com. So since this is an international program, we want to know, where are you guys Zooming from today? Drop it in the chat, please. You are welcome to do so. We want to know. Okay, wonderful, wonderful. Thank you guys so much. I myself am calling from the beautiful island of Puerto Rico, so we want to welcome you guys from all over the world. Thank you guys for coming in. So if we want to stay in the loop, follow us on social media. We are active on Instagram and TikTok. And you can also sign up for our email list on our website to never miss a session. We have as well wonderful opportunities for you all as benefits of being part of our program. We have partnered with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources, such as study guides to help prepare for your standardized tests like the MCAT, the NCLEX, or the PCAT. If you fill out our short survey in the chat, we will get you signed up for these deals for free. We would also like to draw your attention to another amazing program that is Neolith. Neolith is an online mental health platform for students, right? For young adults and college students. We do know that college can be stressful enough as it is in non-pandemic times, for pre-health professionals especially. And we know the path isn't easy. That's why we have partnered up with Neolith to spread the word and offer free access to the services if you use the link in the chat or enter the code PREHEALTH when signing up. Another amazing partnering up that we are following is Mask for Mask, which is an amazing women-led organization that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic. For example, those in the homeless community, healthcare workers without proper protective equipment, and others who are struggling to stay safe. With our discount code PHS15, you can get 50% off your order. If you buy through this method, Pre-Health Shadowing, you also get 10% off the 10% of the proceeds, which is amazing because we are a nonprofit, as I mentioned earlier, that runs solely off of the support of our community. If, of course, you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be a part of our administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and more. We understand that as a pre-health student, you may not have the time. And that is why we also offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We would love to have you be a part of this program and contribute your own unique perspective. Also, great news. If you are a high school student and want to get involved, we have started a program called HTP, or high school training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students interested in medicine through pre-health shadowing. We want to highlight that we love to recognize and want to recognize the hard work of our students in the program. So if you are interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor-in-chief through the link dropped in the chat to have your work on our website. This will look great on CVs, applications, resumes, etc. So do take advantage of it. Part of our mission at PHS is to promote diversity. And in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series on patient experiences, a COVID-19 roundtable, and International Students Forum. If you have a mentor, professor, or professional that has inspired you in any way, and you think they could contribute to these conversations, nominate them using the link in the chat. If you can, we humbly ask that you please donate to our program. As you know, we are a completely student-run, and we are working around the clock to keep this free and accessible to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you are not financially able, we request you send this link to someone you think can, so we can continue to support those who cannot afford similar opportunities. You can also scan the QR code right over here on your upper right corner. Throughout the session today, we encourage you to drop any questions you have for the speaker in the chat, and our team members will be making note of these to be asked in the latter half of the session. Do take good notes as our professional is going over their presentation, as there will be a chance to take a post-shadowing assessment to verify your virtual shadowing hours. More information will be available on this at the end of the session, so stay tuned. Lastly, if you can, we request you turn your cameras on, but we do want to make notice that this is by no means an obligation, as we are respectful of different circumstances, but it does help us feel closer together in a time when social distancing is mandatory. Once again, I appreciate you for listening, and now I would like to welcome Dr. Renee Causey-Upton. Thank you for joining us today, and you may share your screen whenever you are ready.
Right. And thank you for introducing me, and I'm really excited to be here today. Okay, so I believe that everyone can see my PowerPoint, hopefully.
Yes.
Okay, perfect. And so I'm here to talk about occupational therapy. It's a field I'm really passionate about. And so I do have quite a bit to say, but there is time, you know, in the second half of this to also ask questions, and hopefully I'll know the answer. If I don't, I can get back to you with a response. I'd like to say that I know everything there is to know about occupational therapy, but you know, I can't say that that's accurate. I know a lot, but we can always learn more. Okay, so to introduce myself, I am Renee Causey-Upton. I'm an associate professor in the Department of Occupational Science and Occupational Therapy at Eastern Kentucky University. I'm also the coordinator for our undergraduate program, which is a Bachelor's of Science in Occupational Science. And so obviously I teach in our occupational therapy program here at EKU. And I teach across all of our program levels. So the undergraduate, I teach in our master's program in occupational therapy, which we are currently phasing out because we've moved to an entry-level doctorate degree. I teach in our post-professional doctorate degree in occupational therapy. And then also you can see on the slide that I'm an adjunct professor at University of Kentucky. So in that role, I teach some in the Ph.D. program in Rehabilitation Sciences. So that is an interdisciplinary program, and it has some connections to EKU as well. So it's kind of a nice fit. I'm also an associate editor for the Journal of Occupational Therapy Education. So a lot of health professions have had an education journal for quite some time. So there's an education journal for physical therapy, an education journal for, well, multiple, for medical education. There are education journals for nursing and a lot of other professions. So myself and two of my colleagues, Dr. Dana Howe, Dr. Cindy Hayden, we saw a need for a journal that explored research related to occupational therapy education. And since this journal did not exist, we started it. And so we've been publishing for 5 years now, and it's something we're really, really proud of. As far as my educational background, I'm a graduate from Eastern Kentucky University. I have my Bachelor's of Science in Occupational Science. I also completed my Master of Science in Occupational Therapy at EKU. I'd been out in practice for about a year when I decided that I wanted to go back to school. And so I went to Chatham University for my post-professional doctorate in occupational therapy. And then I, started teaching at EKU, and I decided that I needed to go back to school again. So obviously I'm a big proponent of education. I'm a lifelong learner. And so I did complete a Ph.D. in Rehabilitation Sciences from University of Kentucky. Okay, as far as my background clinically, I started working in an acute care hospital. And that was my first, I guess, love of clinical practice. I really liked the acute care setting. And within that setting, I had an opportunity to work with a lot of different types of patients. So we did have a long-term acute care floor where we had clients who maybe they needed long-term antibiotics for a month or two. Maybe they had wounds that were not healing well, or they just had some condition that required a little bit longer term of care. And so I saw a variety of patients in that part of acute care. I also worked on an orthopedic floor where I saw clients who had total knee replacement, total hip replacement. Orthopedics is another one of my clinical loves in terms of settings. We also had a telemetry unit, which would be clients who need cardiac monitoring or maybe have lung pulmonary diagnoses. And I also worked some in the ICU there. I saw some patients in the general outpatient setting as well who had a variety of diagnoses, maybe carpal tunnel syndrome. Could be folks who had a more acute diagnosis, but they actually had gotten better and they were at home now. Maybe they'd recovered from a CVA or stroke and were still needing some care. I also did outpatient pulmonary rehab, and I really enjoyed that. So seeing clients who had diagnoses like COPD or chronic obstructive pulmonary disease who were coming in for more intensive care to help them sort of navigate their world with their limitations in terms of shortness of breath and fatigue and those sorts of things. I also worked in skilled nursing facilities as well. And I worked as an OT, but I was also a rehabilitation manager in that setting too. And I did that for about 2 years where I was the rehab manager. And then I sort of stayed on PRN, which means as needed. So if they needed an OT to come in on a Saturday and do some evaluations, then I sort of filled that role. As far as my work in acute care, even when I left that setting full time, I stayed on PRN. Actually just until the last 2 years. And my life got a little bit busy and complex because I have twin toddlers now. So about the time that the twins were born, I decided, you know what, there's only so much time in a day, and it just wasn't something I was able to keep up with all of my full-time teaching and my other roles. But I think acute care will always be my main love of clinical practice. I always kind of stayed in that setting. As far as my research interests, I've done some research related to preoperative education for orthopedic clients, in particular related to total knee replacement. So sort of looking at what do these programs look like across the United States, what's currently included in those programs, maybe what should be included to improve that and improve patient outcomes after surgery. I've also looked at readiness for discharge. So what are perceptions of clients' experiences in terms of preparing for discharge after knee replacement, and do they feel prepared? Are there things that as clinicians we could do better to prepare them for that transition from hospital to home? More recently, just because my main work now is within an academic setting, I've been focusing more on student outcomes. So looking at things like clinical reasoning. So, what is the impact of a clinical reasoning lab that involves acute care patients and sort of responding to some of those medical changes that can happen in the moment? Can we see an impact on clinical reasoning before those labs and after? And then I've also been looking at this idea of perfectionism. And I know that sounds kind of odd, but perfectionism is a trait that you can actually measure on a standardized assessment. And what we found is that rates of perfectionism are really high among health science students, which is probably most of you if you're here. And so now I'm sort of looking at, okay, we know those rates are high. Is there a relationship between having those perfectionist qualities and psychosocial and academic outcomes? And so I haven't finished that data analysis, but preliminarily, which is a really long word, I am seeing some links there. So we know that health science students are in rigorous programs. You have really high expectations of yourselves, and that can be hard in terms of mental health. So that's kind of what I'm looking at now. Okay, so why did I choose OT? So I had a lot of personal, I guess I can't say a lot, but I had some personal experiences with occupational therapy and physical therapy. The first, I played softball when I was younger, and I broke my ankle stealing third base, and I had a spiral fracture. I had to have an open reduction internal fixation, which if you've heard of like a metal plate and screws or a rod, that's basically what that refers to. And so following that, I had to have some pretty extensive physical therapy. And then as far as occupational therapy, I was in a car wreck when I was a teenager, and I had lots of cuts, stitches. I almost completely severed an extensor tendon in my index finger in that car wreck. And so I had to go see a hand therapist. And so I just kind of was introduced to the rehabilitation field through those personal experiences. I also had some family experience with persons of different abilities. And so my father was born in a rural area at a time when the polio vaccine was not fully accessible. And so my father developed polio at a young age, and he had to have a very extensive surgery when he was about 15 years old, essentially having a spinal fusion from C-spine all the way down. And he could not sit up without a full back brace until he had that surgery at 15. And so he had a lot of impacts from polio, but I can tell you as a child, I did not know what a disability was, because all I could see was all the things that he could do. Obviously, I noticed that he walked with crutches. I noticed that he had polio braces that ran from his boots all the way up to his hips, and that's how he was able to walk. But again, disability was not a term I knew. I could just see all his abilities and all the things he was able to do, but that he had to adapt some things. And so I think that early experience also kind of led me to a career in rehabilitation. And then, in addition to those experiences, it also just kind of aligned with my skills and interests. So, I'd like to think I have a caring personality. That's something I've had for a long time. And in the rehabilitation field, occupational therapy in particular, you have to care for your clients. You have to have the ability to develop a rapport with your clients. And in addition to having that caring personality, you also have to have an interest in healthcare and some of those sorts of skills and aptitudes. So occupational therapy seemed like a really good fit for me. Okay, so what is occupational therapy? Here's a nice definition here from the American Occupational Therapy Association. And I won't read it directly to you, but I'll kind of give you my definition, which is, basically we help people get back to doing whatever it is they want and need to do. And we do this through daily occupations. And a lot of times people hear the word occupation and they think, oh, that's a job. And it is, but we consider as occupational therapists, everything is an occupation. So it is a job, but it's also all the other things that you have to do every day. So I woke up this morning, I got out of bed, I brushed my teeth, I washed my face, I took care of my children, I showered, I dressed, I drove to work. I'm doing a presentation now, and I've done other work tasks today. I probably will go home tonight and cook and maybe clean, because my toddlers have probably destroyed the house today while I've been gone. And they keep their aunt, Gigi is what we call her, but she cares for the boys while I'm at work. They keep her on her toes, and so there's lots of things that I have to do every day, and all of those are occupations. And so as an occupational therapist, there's a lot of techniques I can use to help people get back to doing those things that they want and need to do. Okay, so in a really brief nutshell here, what does occupational therapy include? So whoever your client is, whatever their diagnosis is, you're going to do at least these three things, okay? And so every client is going to get an individualized evaluation where you are going to look at, okay, what are the things the person wants to do, needs to do? What are the things they're having trouble with? And obviously you're going to do a lot of really specific things in addition to that. I might need to see a person, how are they doing getting dressed? I might actually need to watch them with dressing, help them with dressing. I may actually need to test things like their strength, their endurance, their coordination, and their fingers. So where are the deficits? Then we're going to work together to set up some goals that are going to guide our occupational therapy interventions. So we've done our evaluation. Now we're going to be providing intervention that's individualized to that client to help them reach those goals that we have set together. And then at the end, we're going to be looking at outcomes. So basically, this is kind of the discharge planning process. Once we've gone through the whole OT process with them, and it'll depend on the setting they're in, how long that takes, what their, insurance company will pay for. That kind of determines sometimes how many intervention sessions I get with a client. But whatever that process has been, at the end, we're going to go through and we're going to see, okay, how much progress did we make? Did we meet our goals? Do we need to change our plan of care? Maybe things aren't going as well as we liked. Maybe they had some sort of a medical issue, and now we need to reevaluate and change those goals, or maybe they've met them all and they're doing great and we can discharge. So that's kind of the process that we go through in a nutshell there. Now, to be a little more specific about interventions, and there are so many types of interventions we can provide, but I wanted to just put a few images up here to show you some examples. So a lot of times we are helping someone adapt an occupation that they want or need to do. So let's say someone has had a CVA or a stroke, or maybe they've had a spinal cord injury and they no longer have a strong grasp with their hand. Well, we might need to use something like a universal cuff, which allows someone who doesn't have grasp to hold something like a spoon, to hold a makeup utensil, or it could be a variety of things. And as long as they have upper extremity movement, they might still be able to feed themselves that way. They might still be able to apply makeup that way. Maybe they can paint that way. And so sometimes we need to help someone reach their goals by using adaptive equipment. You'll see another piece of adaptive equipment in this far sort of right corner, and that's called a sock aid. So this is for someone who, maybe they've had a hip replacement and they've got hip precautions. And this is an orthopedic precaution. Depending on the surgical approach, the person might not be allowed to bend past 90 degrees, or they could risk dislocating that hip prosthesis. So how are they going to put their socks on? Well, they're going to need a device such as this, which will allow them to put their socks on without bending over. And there are all sorts of other adaptive devices. If someone has a mobility limitation, they might need a wheelchair to be able to maneuver within their environment. So a lot of times, again, we're offering adaptive equipment, but we may also have someone who has some sort of deficit that we can remediate or improve. So if I have weakness, I have muscle weakness, then maybe what I need is exercise to improve that. So occupational therapists do incorporate exercise techniques when needed, but we wouldn't only want to do exercise. We also want to make sure that we're focusing on the actual occupation that the person needs to do. So, maybe we have to prescribe exercises, but we also later that day or the next day, we actually do the occupation the client's having trouble with. So maybe they're having issues with putting groceries away in their home. And so we have to work with the client on, okay, for now you have these muscle weaknesses. So we're doing strengthening. In the meantime, let's rearrange where you're putting your groceries. If you're not strong enough or you don't have the range in your shoulders to reach overhead, then we need to put your groceries on a lower shelf. Maybe we need to buy groceries that aren't in large containers that are heavy. Maybe we need to do smaller, lighter containers of food and other items. So there's ways that we might be adapting in the meantime until we're able to improve those abilities. We might also do something called electrical stimulation. So that's a deep physical agent modality that occupational therapists can use. And it's a way to help sort of stimulate and strengthen those muscles through the use of electricity. So that's something we might do as part of an occupational therapy plan. And there are certainly other types of modalities. We could use ultrasound, for example. And I think people hear that and we tend to think of, ultrasound during pregnancy, but this is a different way to use ultrasound, where if someone is having pain, for example, or they're having reduced range of motion or joint range, maybe there's some scar tissue that's developed, then we can use ultrasound to sort of heat up that scar tissue so that the person gets more flexibility, more movement, so they can be more functional. We might need to do splinting for a client. If they have had a CVA and maybe they're at risk of losing that joint range in their fingers, maybe someone's had a fracture and we need to immobilize the joint so that it can heal. There's a lot of reasons that we might make a splint, but that's something that occupational therapists do. And we focus on splinting the upper extremities. So it tends to be more the wrist, forearm, hand is kind of the areas that we focus on. We might do other interventions too. If someone has issues with sensory regulation or integration of input from the environment, so things like movement, what we see, what we hear, those types of things, then we might need to do some activities such as using a swing or deep pressure or something like that that can help a person in terms of their sensory system. So I could really talk all day on intervention alone, but just know that, whatever problem a client has, we use a whole lot of tools to help the client meet their goals. Now, obviously, there are times where something, maybe a person isn't going to be able to do that occupation anymore. So I can think of if a person has a really high level spinal cord injury and they don't have any movement of their upper extremities, then dressing isn't going to be a possibility for them to do themselves, but we might have to train them in terms of how they are going to direct their caregiver to provide them with the assistance they need. So sometimes we have to kind of adjust the client's expectation, but they might be independent in a different way. Okay, so occupational therapy can provide care in a lot of diverse populations, settings, across age groups. And so I just want to talk about that a little bit. And I think that's the beauty of occupational therapy is if you get bored where you're working, well, there are so many other ways to do occupational therapy that I just don't think you can ever truly get bored of OT. You might need to switch settings or something like that, but you really have a world of possibilities. So as far as age groups, you could work in a NICU and work with newborn babies who maybe they're premature, for example, or they just need that extra intensive medical care. So OTs work in those settings. We work with infants who are full term, toddlers, children. We work with adolescents. We work with young adults, middle-aged adults, all the way up to the very old. So the oldest client I've ever had, I think, was 104 years old, and she was spunky. I mean, she really still had a lot of energy and just a lot of love for life. So if you have an interest in a particular age group, just know that that can be a part of occupational therapy. Or if you don't know what age group, there's a lot of variety there. We work in a lot of types of settings. So you can work in a work setting. There are OTs who work in factories, for example, and they treat clients who have a lot of repetitive type of injuries. So think carpal tunnel syndrome, rotator cuff tear, for example. You might work in a more hospital-based setting. You could work in, outpatient center. We have occupational therapists who provide something called Hippotherapy. So if you have an interest in horses, basically this is where you are using a horse in a therapeutic way. And we do this with clients maybe who are veterans who have post-traumatic stress disorder. You can do this with clients who are pediatric and they need that sort of vestibular or movement type of input from the environment, and they get that from being on the horse. Some of the movements of the horse and the way that shifts the hips, it kind of mimics gait patterns at the hips. So I know that's a really unique sort of setting, but that is one that OTs can work in with some specialized training. When I say continuum of care, I mean the very acute setting like ICU. Then maybe the more typical acute care setting. You might work in an inpatient rehab setting, which is folks who are no longer needing a lot of medical care, but they need a more intense sort of rehab. So they might be getting 3 hours of therapy a day. Now that's not all OT, obviously, but occupational therapy is part of the team, maybe physical therapy, speech therapy, but it's a more intense sort of rehab because the person is medically stable, they've moved on to the next level of care. You could work in outpatient where people are living at home and then just coming in a few days a week for therapy. You could do home health. This is when you're seeing clients in their home environment, so they were stable enough, well enough to go home, but for some reason they're homebound. They're not able to get out except for physician appointments, things of that nature. So there's a lot of settings in terms of that continuum of care. And then we can address so many occupations. And the setting you're in can impact maybe the occupations of focus. So acute care, you're probably more focused on self-care. If someone's in the home environment, you might be working on cooking. You might be working on showering, cleaning. You can see pediatric clients. Maybe you're working on how they're able to participate in the school environment. So there's driver rehabilitation. You can work on folks with how they're able to safely drive and manage that. So just know there's a lot of possibilities. Okay, a typical day as an OT. And I base this more on my experience in terms of being in acute care, but this is kind of similar in a SNF. And this will relate a lot to inpatient settings, but honestly, a lot of those typical things will span all settings. So the first thing you're going to do when you come into work as an OT is you need to review your client list. Who is on your schedule for the day that you're going to be treating? Then you need to review everyone's chart. So you're going to do this no matter what setting you're in, but especially if you're in an acute care setting, for example, you might have clients who are medically fragile. So you're really going to look at those charts closely. You're going to make sure there aren't any new orders that are concerning. So if someone has an order for a stat, which means immediate chest x-ray, or maybe they're testing cardiac enzymes, that's something I'm going to be concerned about and maybe holding treatment. You're going to check the client's status. If you're in an inpatient setting, that means you're going to go talk to the nurse and say, okay, I just want to make sure this client is cleared okay for therapy today. So we're going to do that. If you have any new clients, you're going to go through and complete initial evaluations. So that I talked about the evaluation a little bit earlier, but basically it's your first time seeing the client and you're going to find out what's important to them, where they're struggling. You're going to try to evaluate those specific occupations if possible. Sometimes we can't do all of that in an inpatient setting or sometimes in an outpatient setting. You're not going to have access to do a full shower or anything like that, but you may be asking the client about how they're struggling with that. You might ask them to demonstrate, well, can you reach your foot if you needed to wash your foot? Can you reach if you needed to wash your hair? So some things we might not be able to see fully. And then you're going to evaluate other things like strength and balance. You're going to come up with your goals together. Then depending on how long you're going to have the client on caseload, that's going to determine how many treatment sessions you get with the client. And so you're going to go through and be addressing their goals and their limitations at those treatment sessions. If you're seeing someone in acute care, you might evaluate them one day, they might discharge the next. So you might only get one treatment session after the eval. If you're an inpatient rehab, you might get to see them for 2 weeks potentially. If someone's outpatient, you might get to see them for therapy for, could be 4 weeks potentially, and then you might ask for more sessions for them after that. It just depends on their needs. In the typical day, once you've done your initial evaluations for all new patients that day, you've done all your scheduled treatment sessions, you need to document all those evals, all those treatment sessions. And it kind of depends on the setting and the way that your company or employer has that set up in terms of documenting. Sometimes people document immediately after every evaluation or every treatment session. Sometimes people document at lunch. They document everything that happened from the morning, and then they see their clients for the afternoon and they document all of that at the end of the day. Either way, if you're having to document a large number of sessions together, then you probably want to have taken notes. So this is what I did in acute care. I'd have a notepad. I would be jotting down notes so that when I went back to the therapy room at lunch, I could remember all the information I needed to document. So you have to have some way to make sure that your documentation is accurate and clear. And then you're always going to be communicating with the interprofessional team. So if I think a client needs a bedside commode for discharge home, I need to contact the social worker who's kind of in more of a case management role, at least in acute care. That tends to be the person who fills that role. Sometimes it's nursing. If I notice a change in a client's medical status, I'm concerned, their heart rate's high, or I thought maybe they were a little disoriented. I need to tell nursing, because if I keep that to myself, then there could be something medically happening that could have an adverse effect on the client. And if I haven't communicated that, then no one else is going to know to follow up. So constant communication. There's a lot of additional things you might do as an occupational therapist. You're going to attend meetings. So in some settings, you might have a morning meeting every day, or maybe once a week you have a client care sort of conference where a representative from every member of the healthcare team comes and you talk about all the clients and patients that are on within the facility at that time. So it could be lots of meetings. You're going to be creating educational handouts for clients. Now you might end up, once you've been an OT for a while, you will probably have a nice stash of educational handouts to choose from. But there's going to be a point in time where you need to send some information home with a client and there just isn't an existing handout. And so that's something you might create. Depending on your setting, you might be expected to provide training for others. So when I worked in a skilled nursing facility setting, an expectation was that I would develop training sessions for other staff, so nursing and certified nursing assistants. And so I provided education on things like fall prevention, safe transfers, providing proper assistance for self-care activities. How do you perform range of motion or joint mobility safely to help prevent contractures? So those were some of the things that I led those training sessions for. There's going to be times you're going to be expected to attend in-services for different topics. You might develop programs. So I have developed programs within a SNF setting and within acute care. And so one of the programs I developed was about providing pulmonary rehabilitation in a skilled nursing facility setting. And so that was a manual I actually wrote, and I educated the staff on how to implement that, the rehabilitation staff. Depending on your setting, and maybe if you're trying to start some sort of a new program. And so I was involved in helping to start an outpatient pulmonary rehab program. And so as part of that, I had to seek referrals. I had to go and speak to physicians and say, here's our program, here's what it's going to consist of. Do you have any patients in mind, or keep us in mind in the future and refer those individuals to us? So if you're trying to start a new program in an existing employment setting, or maybe you're going to start your own business, there are OTs who do that. Well, you have to go out and seek referrals to maintain that business. You might have to communicate with payer sources. So that's insurance companies like, Medicare, Medicaid, Blue Cross Blue Shield. So you may or may not have to do this if you're not in a management position, but particularly if you become a rehab manager, this may be something you have to do. You may have to write letters about why a client needs additional therapy sessions. Why should that be covered? You might have to write letters related to a client needing a different mobility device and why that should be covered. So that's something you may need to do. And then depending on where you work, you may be searching the literature. So I'm sure as students, you all have access to a library at your university, and you have to write papers where you have to include sources. Well, as an occupational therapist, if you don't know what is the best intervention for this client, I'm trying to choose between this splint and this splint, and I don't know which is going to work best. Well, then I need to do some searching and see what is the best evidence that can help me make this choice. And you might even be conducting research. You might be involved in research studies in your setting. Okay, I think just briefly, we might want to go to that first polling question. Let's kind of break this up a little bit. So if you, oh, sorry.
No, don't worry, it's already up, and like members should be able to see it.
Okay. So based on this question, who can occupational therapy provide services to from these populations that are listed?
So according to the results, most of our members said that all of the above.
Yes, perfect. I mean, you can provide OT across the gamut of age, setting, continuum of care, all of that. So it's in terms of sort of getting to choose who you want to see, like if you are drawn towards geriatric or if you're drawn towards peds, you can make those choices in terms of where you want to be employed as an OT. I have a few cases that I was just going to talk through briefly, and then I was going to look at the requirements for becoming an OT in terms of applying to schools and programs. So this first case is about a pulmonary client who her main diagnosis is chronic obstructive pulmonary disease. And if you're not familiar with that, people have a lot of fatigue, they have a lot of shortness of breath, coughing, and it really impacts their quality of life. They'll have oxygen levels that drop with this sometimes. And she's got some other conditions here too. She's having trouble with transfers, which that basically means getting from one surface to another. She can't get out of bed. She can't get to the bathroom. She's having trouble with a lot of self-care tasks. And then she's also got functional activity tolerance issues, which is basically endurance. So someone who has poor endurance. She has safety issues, and she has strength issues too. She doesn't breathe effectively. So we actually teach people about effective breathing patterns for COPD. And she also has kyphosis, which is kind of a rounding of the back. And this is not uncommon among folks with COPD because they tend to feel less breathless if they sort of just kind of rest a little bit, I guess, on their elbows. And so over time, they kind of develop that rounding of the back. She has anxiety attacks, urinary urgency, and she's also had some recent weight loss and is just not eating very well. Okay, so this was a real client I had whose name has been changed, but these are some of the things that I did with her. So we did some retraining in her self-care tasks, or ADL, which is activity of daily living. That's kind of the term we use for bathing, dressing, grooming, toileting, and eating. And when I say ADL retraining, that meant teaching her new ways to do those things that would help her be less short of breath. It meant using adaptive equipment for bathing and dressing. It meant doing things like putting her on a toileting schedule so that she didn't get so anxious. She would become so anxious and just really laying on that call light, and staff could not get to her fast enough. So we put her on a schedule to where staff would assist her to the bathroom before it became an emergency. I educated her on ways to conserve energy so she would be less fatigued. I educated her on relaxation techniques, and she really needed that so that she would not be having those panic attacks. I taught her to coordinate breathing with eating, because people who are really short of breath are at risk for aspirating food into the lungs. Because they are so short of breath, they tend to, the minute they take a bite, they want to inhale after. Well, that puts them at high risk for having a choking incident. So I had to sort of retrain her in terms of when she needed to breathe in and out with eating. We did things to increase her strength and endurance, looked at breathing techniques, taught her ways to do that would make her less short of breath. And then we had to do some mobility exercises, thoracic mobility exercises, to sort of impact that kyphosis of her back. Okay, this next case is for a cardiac client. And so this person had some cardiac diagnoses and some other things too, diabetes, obesity. And she had to have a CABG, which, if you've heard of open heart surgery, that's probably the more familiar term. And that was because she had some artery occlusions that needed to be removed. And she spent one day in the ICU. Now she's been moved to a telemetry unit, which is basically, she's in acute care. She's being monitored in terms of her heart rate and some other cardiac features. She's having trouble with bathing, dressing, and functional mobility, or walking, those sorts of things. You know, she has trouble maneuvering around her room and getting into the bathroom at the facility and everything. She's concerned she's going to have trouble when she gets home with things like gardening. She likes to volunteer for a literacy program, and she's having a lot of fatigue issues. She's married and she lives in a one-level home, but she has one step she has to go up to get inside. So one step may not be a big deal for some clients, but it could be a big deal for folks maybe who are non-weight bearing in a lower extremity or something. So we, at an initial evaluation, we want to know how many stairs to get inside. Is there a handrail? How many stairs inside? All that is information that we need. Okay, so for this client, there was a lot of education on her precautions. So she had some cardiac precautions. She needed to be aware of her heart rate and make sure that it didn't rise above a certain level. She had sternal precautions from the open heart surgery, because the sternum has to be cut and it is wired shut after surgery. And so people have lifting restrictions and movement restrictions after surgery. And so those were things that we had to teach her about. And she had to learn how to incorporate those precautions into all of her activities. She could no longer just reach overhead with one arm to grab a can of soup out of the cabinet, because that would have caused some shifting of the sternum. So it really is kind of relearning how to do things until those precautions were lifted. She was able to do some light exercise training within her precautions. She had fatigue, so we also worked on energy conservation with her. Education on risk factors, because someone with a cardiac condition, we don't want them to have a similar issue that in the future results in another surgery. So trying to reduce her risk of future issues. And then adaptive methods for completing higher level tasks. This was a real client too. And in the meantime, I think we talked to her about, how do you do, gardening that's elevated? Can you use a tumbler tomato plant where you're not actually having to get down on the ground, and it's something that's at a higher level that's within her reach. And so she had to adapt her gardening. She couldn't do the way she normally did before her surgery, at least not in the early cardiac phase. And then here's an orthopedic example. And so this was a client who had osteoarthritis, and he underwent a total knee replacement. And this is a typical, this isn't any particular client, but it is a typical client that I saw in practice. He was fully independent before surgery, although he was having more pain. So getting closer to his surgery date, he was starting to have some issues. And then after surgery, he was needing minimal help with dressing and bathing. He is married, lives in a one-level home, but he has 4 steps to get inside. He does have a handrail on both sides, so that will help him in terms of getting into the house. So one of the big things we do, and we're limited on time, because this would be a person who would have an evaluation one day and they would discharge the next. So you're just limited on what you can address in that time. But Safety with transfers and self-care tasks is the priority because this is someone who needs to go home quickly. Training in adaptive techniques to make the person more independent with dressing and bathing, making sure they can safely transfer to the toilet and can they get in and out of the bathroom. Most likely, well, everyone after a knee replacement essentially has to use a walker in that early surgical phase. And that's new. If someone was not using a walker before surgery, it takes some training to be able to maneuver safely after surgery, the first time that you use a walker. So that's something we work on too. And then making sure we provide good discharge recommendations. So does this person need any equipment at home? Are they safe to go home? It's rare, but sometimes people might need to go to inpatient rehab after an ortho surgery like this, but I will tell you that's becoming less and less common, and that insurance providers do not want to pay for an inpatient stay after acute care. So you'll see that less and less folks going to another setting. Okay, so this is probably what many of you are interested in. Well, hopefully it was good to hear about OT, so you have a better idea about whether or not this is something you actually want to do. But now we're going to talk about the requirements more specifically. So currently, you can enter the field of occupational therapy with either a master's degree or a doctorate degree. And that's a decision that was made. Many healthcare professions, they'll have something called an accrediting body. And basically that's a group, an organization who decides this is what is required for you to learn. And this is the program level that's required for you to complete for you to become an occupational therapist or a speech language pathologist or whatever profession you want to enter. And so our accrediting body, which is called ACOT, has decided that we can have dual entry, that master's or that entry level OTD. So either one of those would allow you to enter the field. You must also successfully pass what's called the NBCOT exam. So that's the National Board for Certification in Occupational Therapy exam. So you do have to pass that as well. As far as maintaining your ability to continue to be an OT, well, you have to get your initial license once you pass the NBCOT exam, but most states require you to also get continuing education yearly. So in the state of Kentucky, where I live, we have to have 12 hours of continuing education units every year in order to maintain licensure. So it depends on your state, wherever it is that you will be working. Okay, actually, I think we can do our second polling question now.
It is up.
Okay, so current students in the US must graduate from which of the following types of programs to become an occupational therapist?
I will be closing the poll right about now. Okay, so most of our members said that you need a master's or a doctorate's degree.
Yes, very good. Now, I did see some people put associate or bachelor. What I will say is that around 2004, I'd have to look at the exact date. Before that time, people could graduate with a bachelor's degree in occupational therapy and practice as an OT. After that time, new graduates had to have the master's degree. So that was when that switch happened. So you will still see occupational therapists practicing who have a bachelor's degree because they're sort of grandfathered in because they graduated before those changes happened. Now I'm focusing on occupational therapists, but there are also occupational therapy assistants. And so that is a different type of educational program. And currently, you can enter to become an occupational therapy assistant at either the associate or bachelor level. But there's some things that OT assistants are not able to do that OTs can do. So for example, an OT assistant would not perform an initial evaluation and they wouldn't establish the plan of care for what the individual's therapy would incorporate, but they can follow the plan of care established by the occupational therapist. So they might be providing some of those interventions I talked about earlier. They would not really be involved in the discharge process either, but there's a lot that OT assistants can do. And if anyone has questions about that, we can talk more about that a little bit later. Okay, so we talked about, okay, how do you become an OT? And I'm going to talk more about education requirements in just a moment. I just want you to be aware that there are, quite a few advanced practice areas that you could pursue if you wanted to later as an occupational therapist. So the American Occupational Therapy Association, it's the National Association for OT, and they offer things like board certification. And so this can be in things like geriatrics, mental health, pediatrics, for example. They also offer what's called specialty certification in areas like driver rehabilitation, feeding and swallowing. And for many of these advanced practice areas, essentially, there's probably a training program requirement. You might have to have a certain number of hours working in the area, and then you're going to have to pass an additional examination. So just know that's a requirement for essentially all of these here. And there's many others. I just couldn't list them all, but you might be interested in becoming a certified brain injury specialist. And so for this, you have to have, I want to say 500 hours of work practicing with individuals who have brain injury. And then you do have to take a certification exam to be able to put that credential after your name, the CBIS. Deep physical agent modality certification, that's something that's required in some states. So for in Kentucky, to utilize things like ultrasound and E-stim, you have to get that certification. Whereas in other states, you might be able to practice those modalities and you wouldn't need that certification behind your name. So something to be aware of is that some of these things vary by state. But the national components of going to a master's or doctorate level school, passing the NBCOT exam, those are all required across the US. You could become a certified lymphedema specialist or a therapist, a hand therapist, assistive technology provider, and again, many others as well. Okay, because I'm at EKU, I'm wanting to give you a really specific example of the admissions process, and then I'm going to show you generally what might be included in other programs. There are hundreds of programs, so I just can't show them all to you, but I will show you where to look, actually, if you're interested in obviously looking at other programs across the US. So currently, EKU, we have a Bachelor of Science in Occupational Science and combined occupational therapy doctorate program. And some of our requirements for admission are you have to have 60 hours of coursework completed prior to applying, and that does include required prerequisite courses, which are listed here. So this is Anatomy and Physiology 1 and 2. We have a statistics requirement, an Introduction to Psychology requirement, and then this HSA 200 is medical terminology. So those are all of our prereq courses, in addition to having 60 hours of coursework total. We do require an overall GPA of 3.0 or above. There's a lot of research evidence to support that this pre-admission GPA has a significant impact on performance in occupational therapy and other health programs. So that's one reason you're going to see GPA included in a lot of OT admission processes. We also require a minimum of 4 Bs and 1 C in the prereq courses. We used to have a requirement that there was a limit on how many times you could repeat a prereq course. And we removed that requirement because we sort of had searched the literature and we had not found a lot of evidence to support that. So that was something we got rid of. I'm on our admission, progression, and retention committee as the undergraduate coordinator. And so I searched for research articles about what should be included in an admissions process and what's the evidence. So we kind of made some shifts there. We do require the health science reasoning test. And this is a pretty inexpensive test compared to like the GRE, for example. The HSRT is only, I think, $15. If you do it in person, there's an online option, which is a little closer to $20. And it's kind of a measure of clinical reasoning. So basically there's scenarios within the test, and you have to sort of choose what's the best course of action. And we've actually seen a little bit of a difference in terms of our average admission GPA. It's gone down a little. And we think it's because of this health science reasoning test, because it's giving people an opportunity to show maybe they've got some good reasoning skills, even if they don't have the highest GPA. So we think it's actually sort of changing our demographics a little, and we're getting some students with some good solid reasoning skills. So we think that was a good addition. Personal statement and resume. So kind of like a short essay, and then sort of a list of things like previous experiences, leadership, those sorts of things. And then there's letters of recommendation that are also required too. And if you were interested, here's our website. I do want to move to more general. And this is because admission processes can really vary across universities. I mean, there's some things that tend to be common, but most programs are going to require some sort of an application form. Most programs are going to have some sort of minimum GPA that's required for admission. A lot will have prerequisite, I would say a lot, or probably all, are going to have certain prerequisite course requirements, which is typically going to be things like anatomy, physiology, statistics. Some programs will require physics. Our program does not. So you do have to pay close attention to see, okay, are there some differences in terms of what's required? Sometimes they'll require resume or essay. Some programs require an interview, which could be in person or could be virtually. Now, due to COVID, I don't know how many universities are doing those interviews in person. I'm not sure, but that could be a requirement, and we have seen that some across the US. Some programs do require shadowing or volunteer hours. Other programs do not. Our program does not require those, but we like to hear about them, but it's not a required component. So, but again, just pay close attention to those. And then there could be a standardized test like the health science reasoning test, the GRE, or could be some other sort of standardized test. Okay, this I just wanted to show you. This is actually an article that was published in the Journal of Occupational Therapy Education. And this was a research study that basically explored, well, what are the common admission requirements for entry-level OT programs? And so they did this. One, they did a survey, but they also explored all of these program websites to try to get this information. And so you can see here that the GPA is really common, recommendation letters are common, quite a few required observation hours, essay. The ODCUS is sort of an application system that you can go through, and some programs, quite a few programs require that. GRE and interview was used by about half of the programs, at least, that were included here. So that kind of gives you an idea of what is common. And then here's the doctoral programs. There are less doctoral programs currently, but you're going to see, I think, a shift in that direction, but it's not a requirement yet. Now, physical therapy is a required entry-level doctorate. So they no longer offer the master's anywhere in the US. So I don't know if someday in the US we will all shift to doctoral or not. But even so, anyone with a master's would be grandfathered in, much like anyone with a bachelor's. So if the requirement at the time of graduation was a master's and that's what you had, then you would be fine to continue practicing with that. So again, that could be a shift we see. I'm not sure, but okay. I would like to go ahead and do that third polling question.
I am sorry. Give me a moment. Okay, now
Okay.
I think I can. Okay, there we go. It's up.
All right, thank you.
You're welcome.
So which of the following are common requirements for applying to an occupational therapy program?
And we'll be closing the poll now. These are the results. Most of our members chose all of the above.
All right, very good. So all of those are pretty common. And I think let's go ahead and do the fourth one too.
Okay. Number 4. Okay. There we go. Now it's up. You guys may answer.
So occupational therapists must meet the following requirements to practice clinically.
Okay, you guys, I will be closing the poll and now. And here are the results.
All right, very good. It should be all of the above. So yes, you have to complete the degree from an accredited program, pass the NBCOT exam, and then pretty much every state requires some sort of continuing education each year to maintain your licensure. All right, very good. So I wanted to give you some advice and tips, and I'm going to show you a couple of websites too. So my general advice to you is to really explore programs that you might be interested in to see what are their specific admission requirements. Because if you're looking at a program that requires the health science reasoning test, and that's the only test you take, but you're interested in a different program and they require the GRE, then you need to make sure you've allowed enough time for both of those exams and getting them completed in time. Or there could be other requirements. You know, you've taken certain classes at your university and you think, oh, I've met all these pre-rep requirements, but you know, maybe there's another program you're interested in and they require a different class. So just be really, really aware of that. And actually, I'm going to go ahead and show you how do you find out about programs you're interested in. So I think one of the best ways is to go to the American Occupational Therapy Association website, and that's just aota.org. And then you're going to go under Education and Careers, and then find a school. Now, I think probably the most useful thing is the school directory, and it's going to link you to ACOT, which it's fine to just go to their main website, but I think it's pretty easy to find this through AOTA in terms of getting to that link. And here you can see links to click on basically every single program in the US that's accredited or in the process of getting accredited. Now, if you're looking at OT assistant, you would go to associate and bachelor level. If you're wanting to be an occupational therapist, you're going to click on master's or doctorate. And so I can click here and get a listing of all the programs. Now, if you know a specific program that you're considering, then it would be easier probably to just go by state or go by the institution type if that's part of your consideration. But if I know I want to go to school in, I don't know, Colorado, then I'm going to search there. And there are 2 at the master's level. But if I think, well, I might be interested in the doctorate, then I can go back to the doctorate and search Colorado again there. Now, maybe it doesn't matter as much to you. If you're not concerned if it's master's or doctorate, then you're just searching by the state under both of those. But if you know you want a doctorate program, then you would want to click on the doctorate and vice versa, if that makes sense. Now, you can go to their website directly from here. Or no, I apologize. That's to send an email. You should be able to click on, view program website. But if you have a question, here's the person to contact, right? If you've looked at their website and it's unclear to you what their requirements are, then you have an email contact. And so once you get to their website, you'll want to search for their occupational therapy program. And you should be able to find their requirements for admission through the website. Again, if you're confused, it's unclear, I would just email the program to get specifics. So let's see. Let's look at their requirements here. So applicants from a diverse backgrounds are encouraged to apply. They require a 3.0 GPA. You have to submit through OTCAS. That was that application system I just mentioned quickly earlier. And then here's a list of prereq courses. So there are letters of references, observation hours, and then here you've got more information again about, well, submitting your transcripts, all of that. But that's how you would find for a specific program. So hopefully that's clear, because I know it can be confusing. Well, how in the world do you even know what programs exist? Well, that's how you know, is going through the ACOT website, or again, I think it's easy to go through AOTA's website and then use the school directory that way. Okay, so some other recommendations I would make are to shadow when possible. I know we're living in COVID, right, at this current time, but not just because it might be a requirement for applying to a program. I mean, that's a really good reason in and of itself, but to make sure you want to be an OT, I think you need to talk to OTs. And if you have the chance to observe in different settings to see, is this what I really want to do? Then take advantage of that. And again, I know we're living in weird times right now, so it's not as easy to do that as it used to be, but that would be a recommendation. And if you can't observe directly, talk to people. What is your day like? Tell me about what you do. I would recommend that. Because so many programs require that minimum GPA of 3.0, and I can't say all, it could be different for some universities, but that's a common one. And they require certain prerequisite coursework, and sometimes they require certain scores in that coursework. This would be a big focus in terms of applying. It is trying to make sure that you're really putting a lot of time into your studies and trying to maintain that overall GPA. I think it's helpful to get involved in service and leadership. It's not necessarily it's not a requirement at my university, let me say that. But I just think it helps you develop some skills and things you will need as an OT. And you're going to be doing things in your classes where you're expected to take on leadership roles. And you're going to do that in practice as an OT. So I just think it's good experience, but it's also something you can put on a resume when you apply. Even if it's not required, it might make you stand out to show that, hey, I'm a chair of this sorority committee or whatever it happens to be, or I've done service with Hope's Wings or whatever organization. So I think it's helpful on a resume, but also helps develop some skills. If you're trying to transfer to another university, obviously reach out to the transfer office. That's one of the biggest things I can say is get in contact with the program and the transfer office at the university, because they can provide a lot of assistance. But also utilize course equivalency guides. Now, I can't speak to what these look like at every university, but I just wanted to show you quickly what this looks like, at least for our university. So if I'm unsure, and the transfer office again can help you, but if I'm not sure, I don't know if this class I took meets this requirement, many universities have this guide where you can sort of look up an equivalency. So the tricky thing is that it's separated by state, it's separated by university, but let's say I want to know if a course from another university in Kentucky will align with something that I need at EKU. So I'm just going to go to University of Kentucky for now. And you've got a subject listing. Something I will say is that some universities use a different sort of abbreviation. So if I think I want to compare biology classes, it might be listed as bio, or it might be listed as bio-L. Here it is, there's bio. Sometimes a class like neuroanatomy is listed under bio, or it's listed under an anatomy abbreviation. So just know you might have to try some different abbreviations. So I'm going to go to ANA and see, does that equate to an anatomy course at EKU? And I already know this because I had to look this up the other day as I was assisting some students with advising. But so we have a requirement in our program as a prerequisite, Human Anatomy and Physiology 1. It's Bio 307 at EKU, but It's ANA 299 at University of Kentucky, and that's an established course equivalency. What I will tell you too is that, you know, if you are applying to our program or other programs, I imagine other programs do this, is that sometimes there's not an established course equivalency in a system, but maybe the course you took really is really similar to our course that we require, or the course that University in Wisconsin requires. So reach out to that program and see, do they do a syllabus review to determine, yes, we'll accept this course. So I do this all the time over the summer, or well, before students apply, they'll email me and say, oh, I'm really worried. I thought I had my anatomy and bio, or I thought I had my medical terminology, but it's not looking like it's going to be a direct transfer. And I'll say, get me a syllabus, send it to me. I'll review it. And if it aligns with the content of our version of that, then we'll accept it for the purposes of admission. And then at some point, someone's going to have to go in the system and put in what's called like a petition to get it accepted directly on your transcript. And so that's something that I do in my role. And likely there's someone wherever else you would apply who would be doing the same thing. So that's just a kind of an insider tip. I think sometimes students don't know that we can do that, but that is something that we can look at. And of course, if you have questions about a specific program, reach out to that program. I don't have a lot of references, but there were a few things I did reference. Before I do questions, we have one last polling question, and it's a little, I had it at the end, but it was something we talked about earlier, but let's run that question and then let's do kind of Q&A for whatever questions the audience has.
Okay, so here it goes. You guys should be able to see the poll right about now.
So all of the following are advanced practice areas that an occupational therapist can pursue, except
okay. I will be closing the poll right now. So these are the results. 67% said canine rehabilitation therapist, and the other percentages were assistive technology provider and AOT board certification.
Yes, so it is canine rehabilitation therapist. I will tell you, I love animals and I love dogs, and I actually looked into this. Physical therapists can go through training to become a canine rehabilitation therapist and work in like a veterinary setting, providing rehabilitation to canines. Occupational therapists cannot get this certification, but if they go through the training program, they can work under the supervision of like a veterinarian who has that training designation. But we technically cannot pursue that designation and have that apply to us as OTs, if that makes sense. But I looked into it because I do love animals. So, all right, are there any questions?
Your mic, Jesus.
Thank you. Thank you. Thank you very much. I'm sorry, as I was saying, Jamie says, I'm looking into Chatham to get my entry-level OTD, and they've been granted candidacy status by the code, but aren't yet credited. Should I be concerned about this? And what is the difference between receiving an OTD from an accredited institution versus one that is not yet accredited?
That's a really good question. So, did you say Chatham? Was that the one? Chatham University? Okay.
Yes.
Actually, that's where I went to get my post-professional OTD. They have a good program. But what it means is that Chatham is accredited for their master's program, which is similar to EKU. We've been an accredited program for, gosh, since like the 1970s, but we were accredited with a bachelor's, then a master's, and now we are in the candidacy phase. So it's not necessarily an area of concern, but what it means is that getting accreditation spans years, like 5 years. So that's just the typical process. Now it is true, you have to, if the program is not accredited by the time you graduate, then you cannot sit for your board certification exam. But a program that has been in existence for a long time and who is shifting degrees, this is just the standard process. There's literally no way to speed up the process. So even though they're accredited with the master's, EKU's already accredited with the master's, we still have to go through that, however many years process of candidacy before they'll finalize and say, yes, you're accredited. So it doesn't mean that that there's some concern or that they're on probation or anything like that. That's just the process that a program has to go through, either for initial accreditation or to get a different program accredited, if that makes sense.
Okay, thank you very much.
Oh, yes, you're welcome.
Another question made by Shubi is, do you feel that your lifestyle as an OT is mostly flexible, or are you working hours usually very late?
Are you working hours outside of work? Was that the?
No, like late hours. Do you usually work late hours?
I will say is going to vary by setting. So like if I work in an outpatient setting, maybe there are a few nights a week where my shift is 10 a.m. to 6 p.m., but that's to allow working adults to have more options in terms of their therapy appointments. Or it could be even a little later, but you're probably not going to work every night that late. You might have other days where your day starts at 8 and you're done at 5. It's just people work different kind of hours in outpatient to allow, folks who can't get off work, who desperately need therapy. They might have to have a 5:30 p.m. appointment, but you probably wouldn't work that shift every single day. If you work in like a hospital setting, you tend to have more of the standard 8 to 4:30 time frame. Now, there might be times that if a client comes up from a surgery kind of late, they had their hip replacement or their lumbar fusion, and they got out of surgery later than expected, then you might stay late to evaluate that patient just because it's an orthopedic patient and they really, really need that eval. And we hate to make them wait till the next day for that, if at all possible. You're not going to stay there till 9 p.m., obviously. But again, if you can stay late and catch that patient, then you're probably going to be expected to try to do that if possible, or someone on the team. Obviously, if you just can't stay, and I'm figuring this out more and more with all of my trying to juggle all my responsibilities and being a parent. Sometimes you just can't stay, So I think you have some flexibility. If you work in SNFs or skilled nursing facility, you can have some longer days there, but you can also have some shorter days when patient caseload is lower. So I don't know if I fully answered the question, other than to say that it can vary. If you're in a school system, you're going to be done when the school day is over, other than you might still have to stay and write notes, but you probably wouldn't have clients after the end of the school day. So it can kind of vary.
Okay, great. Okay, so another question is, do you recommend watching one of the AOTA speakers that are due in April to see if they have any good info to learn as pre-OT students? Or is it more of an actual like OT and OT students that we should be talking about if we're pursuing the OT career?
So you may be talking about the AOTA conference. Their annual conference is in April. And a lot of that is directed at clinicians. Now, if they have a student track, then you might want to look at that, but it may be more directed at students who are already OT students, if that makes sense. So if you know some folks who are currently OT students, I think they would be great to talk to. If you know any OTs in the community, reach out to occupational therapy programs if you have questions about their specific programs. But I don't know that that conference will be may not be as useful to use a student who is not currently in an OT program, if that makes sense.
Yeah, for sure. Thank you so much for that information, actually. Okay, so Brandon asks, what do you look for personally in a personal statement, and what are some outstanding qualities of great personal statements you have maybe taken into account earlier in your career?
So what would I expect in a personal statement, like if someone were applying to our program? So, we're actually looking for things like diverse experiences, and we look at diversity broadly, but that's something we're actively seeking. So if you've had different types of experience, if you have different diverse characteristics, we like to know that. We like to know things about work experiences that might be relevant, leadership, service. Some people have personal experiences with disability, and we would never ask anyone to disclose that, but sometimes people do, and they say, this is why I'm in this OT field, because I've had this, specific experience in my life. And so, we're kind of looking for things like that maybe, set you apart some, because OTs work with diverse clients, and we have to work sometimes in, can be stressful environments sometimes, or things like that. And so if you've had the experience of handling and managing that well, we'd like to hear that. I'm sure there's other things too, but those are kind of the things that stick out currently. But
Thank you. Okay, so another question is from Alana, and she asks, what pulled you to the acute setting in particular? What was it about the acute setting?
oh gosh, well, I will say I had one of we call them level 2 field works. So people might call it an internship if you're in other fields. And that's kind of that big internship at the end of an occupational therapy program, which has to be a minimum of basically 6 months. So you typically do 2 internships. You do 1 3-month in one setting, 1 3-month in another. And my first setting was actually an inpatient rehab. But so it wasn't acute care, but it was kind of a little more medically based in a sense, in terms of the nursing staff and things like that. And then my second rotation, I was split between several settings. So I did some outpatient pulmonary rehab, I did some acute care, some ICU. And so I got exposure to that on my field work. And I just have always kind of had an interest, I guess, medically. And so I don't know, it just kind of aligned with my interests. And then I had that experience on my field work too.
Okay, great. So Kimberly asks, what advice do you give someone who is wanting to become an acute care OT? I am a junior currently and will be applying for OT school this upcoming fall and have been interested in acute care.
I would say that, if you get a chance to observe in an acute care setting, I think that would be great. But also know that every OT program, you come out what's called a generalist. So what I mean by that is to say that to become an OT, you have to have competency in basically all age groups and settings. And so when you come out and you take that certification exam, you have to demonstrate your knowledge in all those areas. So you're going to have some acute care knowledge just based on your program, but maybe you want to seek some more medically based classes if they're offered in your program. Maybe you request of the fieldwork coordinator, that's the person who sets up your rotations, say, I want to go on an acute care fieldwork rotation. You have some level 1 fieldworks a little earlier in the program, which sometimes you're in a setting, or sometimes it's more a simulation. But if you get the opportunity on your level 1 fieldwork to go somewhere that's more medically based, then that I would ask, I would tell the fieldwork coordinator, I really want to get an acute care rotation. And then I would try to do probably some observation too. That would be my biggest, those recommendations.
Okay, thank you so much. And okay, for our last question, HM asks, how often do you see codas pursue an MOTD, OTD, and will being a coda or having attended a coda program affect the opportunity to attend an MOT or OTD program?
You know, it's interesting you say that because we currently have a student in our entry-level OTD program who is a coda. So it's funny that you asked. But so being a coda, sometimes there are bridge programs that will help bring you up to the requirements for the OT, you know, entering the field as an occupational therapist. And there are a few of those you can actually look at through AOTA's website. They'll call those bridge programs. And so that's something you could look at. For our program, we have certain requirements. We don't have a bridge program, I guess is what I'm saying. So even if someone comes in as a coda, they still have to go back through all the requirements of our program for being an occupational therapist. And our program is that BSOS to OTD. So that means even students who come in with a prior degree, they're still completing that BS component. Those 2 of the doctoral years are kind of in that BS degree, and then the other 2.5 are in the doctorate degree. So it won't impact your ability to become an OT other than you can either go the bridge route, or you would be completing the same requirements as a student applying who was not a coda, if that makes sense. So some OT programs, all students come in at the graduate level and you have to have a bachelor's in something else. So if you had a bachelor's degree as a coda, then you would just complete the graduate portion. If you had an associate degree as a coda, then you would have to finish out and complete a bachelor's for most programs. Hopefully that was clear, but.
I'm sorry. Well, they just answered thank you, so I do believe
good.
it.
Okay.
It was clear for them. So we'll be wrapping up this session. Once again, thank you so much for this presentation, Dr. Causey-Upton. And I think we all definitely learned a lot about the OT profession and more about its importance in the healthcare field. So I will be presenting our wrap up presentation in order to finish.
And I apologize that I did not leave more time for questions. I'm really passionate about OT. Time got away, but I could put my email in the chat if that helps for anyone.
Oh, of course, please, by all means do so. Okay, so in order to finish this live session, we would like to invite everyone to reflect on this session today, right? So what brought you today to the session is what are 3 major takeaways you got from it? And what do you want to learn more about this profession or regarding other professions in the healthcare setting? You know, let that sink in a bit. You can write it in, you can just think about it, whatever feels right for you. We do want to highlight that this writing or reflection is not required. However, we encourage you to submit it to our website for publication for recognition of your hard work and to enhance your future applications, as I mentioned earlier in the session. Also, if you want to learn more about pre-health shadowing and getting involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and social media promotion. And we are also accepting team members' applications if you want to take on a more active role in PHS to lead projects and initiatives to be up here with us. Once again, we are humbly asking that if you are financially able to do so, donate a few dollars to us via Venmo or PayPal. It costs a lot to keep our program up and running and free to all of you. So if you're someone who can't afford, or if you know someone else who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. Otherwise, We simply ask you spread the word about pre-health shadowing to reach as many students as possible. Now, for the part we have all been waiting for, earning your digital certificate for the virtual shadowing hours from this session today. Number one, the first step is going to be go onto our website and find our professionals course pages for today. In this case, Renee, Dr. Renee. Next, you can take our quick 10-question multiple choice quiz based on the content from this session today. Note that you will have 30 minutes per attempt to earn 70% or higher to get your certificate. We know that sometimes technology can be difficult, and for this reason, we allow up to 2 attempts to take this assessment. But if you run into any other difficulties, please do contact us. To ensure that our website does not crash from a high influx of students, we recommend you guys wait a little bit, maybe 30 minutes to an hour after the end of this session to take the quiz, which will be open, of course, indefinitely. Once you have passed, you can click the Finish Course button at the bottom of the professionals page and download your certificate verifying your virtual shadowing hours. If by any chance you missed a part of this session or want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the professional pages on our website and take the post-shadowing assessments for these as well. Be sure to follow us on social media or subscribe to our email list just for the latest updates on upcoming sessions and events. We are currently booked every weekday through June and for virtual shadowing sessions, so we definitely hope to see you guys there. Once again, thank you all for joining us today, and please stick around if you have any other questions, and myself or other team members will be happy to answer them. This session is officially over, and I invite you all to log off. Do have a wonderful day.